Welcome back, everyone. This is the hearing regarding Encompass Health Rehabilitation Hospital, Branford's application to establish an IRF in Branford, Connecticut. So let's finish cross-examination by the interveners of the applicant witnesses. We're going to pick up with redirect by applicant's counsel for witnesses.
Thank you. Hearing Officer Chukut, for the record, I just want to state that we produce the PowerPoint presentations 24 hours in advance of the hearing as requested. I have no redirect of Ms. Chafin. I have maybe one or two questions. Mr. Gooch, Mr. Cowherd questioned you regarding Yale, New Haven, Milford, Lawrence and Memorial, and Midstate at Hartford Healthcare. Are those providers located in primary service area? And Mr. Cowherd reviewed with you financials in the CO and application projecting revenues. Do you recall that?
I do.
And were those projected revenues based upon Encompass's experience in opening new facilities?
Yes, they are.
And does the percentage of revenues for Medicare and Medicaid reflect the patient population served at Encompass's IRF facilities, including proposed Branford and Danbury and Johnston facilities?
Yes, I do.
Nothing.
Thank you. So now we will turn to cases in chief of the interveners. I assume you want to start with Gaylord first. But so I think I allotted 30 minutes. So it's 2:50 right now, so let's try to wrap this up by 3:20. A little bit after.
We're waiving any sort of introduction also. I'm just going to defer to our two witnesses. So that will speed things up. Well, first thing I want to do is I want to introduce you to our first witness, which ready to go.
Yeah.
Ready to go. It's fired up. Peter Velding is the chief operating officer, COO of Gaylord Hospital, and he's also the Institute. And first thing I want to ask you is whether you adopt your pre-filed testimony.
But before you do that, let me swear you in.
Or that's a no.
Please raise your right hand. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence that you shall give or have already given in this case shall be the truth, and nothing but so help you God or upon penalty?
I will ask you again, do you adopt your pre-filed testimony?
Thank you.
Thank you very much for your time today. I will try and be brief to respect everybody's time while incorporating all that we've heard today. I'm a physical therapist by background. I've been at Gaylord Hospital for 22 years, and my CV's in there to look at further my experience with any questions. I'm going to focus on the negative impact of this proposal in three key areas: population overlap in the census, training for healthcare providers and professionals, and research of best practices, and third, workforce shortages. So from a population over standpoint, first I want to focus on quality. I'd like to thank Dr. Charbonneau, Dr. Asbani for their compliments on the quality of our care. It's something we take great pride in. We are CARB accredited, which is for accreditation of rehab facilities, specialty accreditation. We actually have specialty accreditations beyond just inpatient. Stroke, spinal cord injury, brain injury, both in and outpatient. We're actually the only one in the country with those specialty certifications. We're one of 18 model systems, SCI, spinal cord injury model systems, which are conglomerates of working on research and best care practices. They're a very extremely competitive process to be part of that. We've been that for close to 20, I think it's over 15. And interestingly, we had a donor come recently. He's the front of a large organization that's donated money across millions of dollars across the country. Came to us. He's been to every rehab hospital, the major names throughout the country, LTACs, and he said he came in thinking we were doing it as part of due diligence, and left saying that we're one of the best. We've heard that from others, from patients that have come from other sites, but for somebody that actually goes to them all to say that we're one of the best in the country, something that we're very proud of, and something that we really strive for that. And we've been doing that since 1907, since we opened in Connecticut. And that's what we want to provide to the residents of Connecticut. We see an overlap of this territory. We talked a lot about this territory today and the data in different ways and looking at it. So the territory we're talking about has had patients per our trial data with from 6 different IRFs and 2 different LTACs. And as we've talked about, the analysis has excluded LTACs in large portions of their analysis. So we have trouble, and my colleague George will talk more about the data in a little bit. And we further have, throughout their statements, they say that their all votes argument, when they open it, everybody does better. We actually have demonstrated evidence when Hartford Hospital opened their IRU, we actually decreased by 35%, and that pertained for over 7 years. So there is a distinct difference when an IRU opens up that we've noticed from a long-term provider that still provides to us, but still at a lesser rate. And that's about half hour. We're about a half hour away from there, and Branford's even closer than that. We've talked a little bit about the overlapping diagnoses. We introduced our sort of Venn diagram to try and demonstrate that visually. Of those 13 diagnoses, we overlap about half of them, and we agree with them. There's diagnoses we don't take. Hip fracture, for sure, that's not going to qualify for us. And they won't take the patients on a ventilator. That's what we do. There's a serial number of diagnoses that do overlap, and that we both provide care for, and both appropriately screen in the beginning. But there are those pieces we can actually accept those patients earlier and help our acute care partners by getting them out of the hospital sooner, helping the flow of the continuum. And that's really important in a state where we have these backlogs and ICUs. We look at all our acute care partners on a regular basis, how we can help things through, how we help with authorizations and all the challenges we've heard about Medicare Advantage. So that's really important. Also, that all happens, that earlier acceptance happens while we're doing 3 hours of therapy for the vast majority of our patients. At any one time, 70% of our patients are receiving at least 3 hours of care, 3 hours of therapy a day, sometimes more. And that goes into Saturday. And on Sundays, we do therapeutic recreation. So we're really trying to bridge the whole gap. It's not just 5 days. And we have that care from our doctors, where you heard about the regulations in different areas. It's not just 3 days a week for physicians. We have a physician there 24/7, because we're providing a higher level of care for those similar type of diagnoses and able to help the different groups as we go. Let's see. And we're doing that at a cost less than the national LTAC rate. So if you look at the Medicare compare data, we're at 0.88 to the 1, so 88% of what would be the average rate. And as we showed, and actually they showed in their data, it's actually better than an IRF daily rate. So again, while providing very good care there. Some other quality metrics that I wanted to mention, our fall rate for 1,000 days is 3.2 for fiscal year 25. I think Encompass was talking about 5.66. So again, we really focus on our high level of care, but also discharging home. So there's been a lot of data thrown around, whether it's by a specific payer class, by national, by regional, by what it may be. We'll discharge home. We look at the patients or the people that we treat and try and help better. We pride ourselves on getting people home, even though we have some of the sickest patients. So our discharge home rate is about 50% for all payers, because that's what we look at our group of patients. And that's really important to us as well, that rate success there. Our occupancy has been 82% over the past 7 years. And that's, not before Hamilton's in Waterbury. And, with Danbury only at about 50% full rate now. And then we're talking about this other site. So there's that could materially change. And I'll talk a little bit more why that's really important soon. And then if we saw a need, that we would do it in partnership with partners as well. We saw that need for rehab, more further beds, rehabilitation. That's something that we would do based on our relationships. And then importantly too, we follow up with our patients long-term. We have 30+ years patients that have been coming back to us. So we do outpatient therapy. So those patients with spinal cord injury, they come back and we're able to help them through their And then one last, trying to incorporate some things throughout. We had 45 patients from Branford last year, just last year alone, and then another 100 just in the towns directly surrounding that town, getting away from some of the zip codes. So while we talk about our people going to travel, we see it across the state. It's basically like a bullseye. It goes further, out from there. So, and we have people from Rhode Island, Massachusetts, New York every year, much less all the way across the state. So people in Connecticut do travel for quality care. Second, from a training perspective, we noticed a need for physiatry. It's a demand throughout the state. The acute care hospital is looking for physiatrists. We are as well. So we partnered with UConn and Hartford Healthcare to develop for even our residency program that we were out of. And we risk if these patients and diagnoses are taken away from us, that they will risk falling below the minimum thresholds that those residents need to complete their education. And actually, the Yale residency program that opened second after us is struggling just with that right now, trying to find the sites that they could to work with for these things. We partner with 30 academic institutions across the multiple areas, and we, and across multiple disciplines, and including those are 100 nursing students a year. And again, if we change the caseload, that could risk the education of those providers going into the community. From a research perspective, we've had outreach from countries across the world. I think we're at 18 different countries looking for our best practices, the research we provide, the new ideas, and oftentimes we're looking to partner with other rehab institutions to broaden and expand our because it's tough to do at any one location. So again, if we're cutting that down, that knowledge isn't shared across the care continuum. Finally, from a staffing perspective, we all know the dire situation that nursing staffing is in throughout the state. We've talked about there's a lot going on there. We also see it in respiratory therapists, and this is before PAM opens or this proposed site. And those could cause safety issues at our site and across all the acute care hospitals as well. Further, the Encompass talks about using CRRNs, certified rehabilitation nurses. We have, I think, close to 40 now, and those are, need to come from someplace. So when we say that we're not going to pull them from different areas, those are people that probably work as well at a hospital for special care as well as us. Those will need, if they're going to be looking for that, that's going to be pulled from someplace. We talked that there's positions unfilled, still on the website for Danbury. And just as a last reminder, we have also we're not just part of the, we're part of the problem, the staffing issue out there, but we've tried to be part of the solution. We created a CNA school, so we contribute to the community with new providers that are out there. And we've seen good success with that for ourselves, but also people going out to other healthcare institutions. So in conclusion, when you compound the lack of need with impacts on staffing, training, research, we have significant concerns the impact of this proposal, especially since it focuses on not just it focuses on the impact what LTAC does, or how it doesn't focus on the impact that LTAC has on the state. Thank
you. Mr. Caracho, do you want to make?
Kiriakou, yes, he's going to be presenting. It's the GK.
Should have sworn him in at the same time. We can get him up on the screen. That would be helpful. Brad? UK. Raise his hand in order to.
Okay, sorry. I had to hit my end as well as your end.
Okay.
Ready to be sworn in.
Okay. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence that you shall give or have already given in this case shall be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
I do.
Thank you.
Mr.
Thank you
Kiriakou,
for-
the first thing we want to do is we want to make sure you adopt your pre-filed testimony.
I do.
Please proceed.
Thank you for the opportunity to testify today. My name's George Kiriakou. I'm the Chief Strategy Officer for Gaylord Hospital and previously was CEO. As the CV attached to the previously submitted testimony shows, My career includes both large and small acute care hospitals as well. I want to comment that I disagree with Ms. Schafrin's comments that there are errors in the Gaylord bed need calculations that she showed, but I'm happy to look at her calculations and do a late file on this if that is of interest to the officers. I also want to comment that I think it's slightly misleading to put 2031 data side by side with 2030 data, since 2030 data was what was used throughout the CON. In addition to the issues identified by my colleague, my concerns, as noted in my previously submitted testimony, are in three areas. The first is the need analysis done by Encompass is seriously flawed. Among other issues, it does not correctly and comprehensively incorporate Medicare program data, and nor does it include Connecticut-specific Medicare data. It also overestimates the percent of Medicare volume and significantly underestimates the percent of Connecticut IRF discharges that are Medicaid. Not addressed by the applicant is that there are two types of Medicare. The first is traditional Medicare fee-for-service, which is managed directly by the federal government. And the second is Medicare Advantage, which is managed by insurance companies such as United Healthcare. Notwithstanding the verbiage I've heard today, there are dramatic differences in the IRF utilization rates between traditional Medicare and Medicare Advantage, both on a national level and on a state level. And these differences were not factored into their bed need analysis. Not factoring in the significantly lower IRF utilization by Medicare Advantage beneficiaries, coupled with not factoring in Connecticut-specific data, results in an artificially inflated bed need calculation, 49 beds versus 13 in our calculation. This is especially relevant in Connecticut since more than 56% of Connecticut Medicare beneficiaries are covered by Medicare Advantage and not traditional Medicare. In addition, the Encompass bed need analysis does not factor in the significant number of rehab patients being served by Gaylord Hospital from those 21 zip codes in that service area. And that's in one of my exhibits as well. The second area of concern is the potentially negative impact on other Connecticut not-for-profit providers who are currently serving this 21 zip code area population, including Gaylord Hospital, Hospital for Special Care, and the Yale Inpatient Rehab Facility. Encompass Branford is projecting Medicaid discharges at 7.4%. Whereas the Yale IRF Medicaid percent for discharges from these same 21 zip codes is 28.4%. We are concerned that based on the actual payer mix of rehab patients from these zip codes, and both for the entire state and specifically for those being served by the Yale IRF and Gaylord, versus the projected Encompass payer mix, that Encompass will try to attract the better reimbursed Medicare and commercial populations currently being served, while the majority of Medicaid patients remain with the existing providers with a significant potential negative financial impact on the existing not-for-profit providers. The third area that we looked at is that we too modified the OHS table reflecting the application of Encompass's need methodology to the state to include Connecticut traditional Medicare and Medicare Advantage utilization rates rather than the numbers that they had put in. And for using those actual numbers for the state as a whole, 106 rehab beds were needed at 80% occupancy versus Encompass's formula indicating 399 beds. We also looked at the 2030 data, and the difference was 418 beds using the Encompass formula and 111 beds using Connecticut-specific data. And that's why we feel it's so important to actually use state data for actual results and utilization rather than abstract national data, especially when that national data is at the 75th percentile, not even at the average, but far above the average at the 75th percentile. For the reasons described here and in our pre-filed testimony, we respectfully request OHS to deny the application. Thank you.
Hey, Mr. Kyaku, did you have any direct questions for him?
I don't believe so, other than to just make sure that you understand that there was a slide presented that showed that where Ms. Chapin did try to recalculate the Gaylord data. And I think that I hope you made it clear that we'd like an opportunity to look at that and submit something in a late filing, do an evaluation so that we as he indicated, it's very skewed and very incorrect.
Okay, yeah, that's fine. And we're going to allow possible for special care to do the same.
Thank you.
So, Attorney Rocha, did you want to conduct cross-examination of either of those witnesses?
Yes, I'm going to cross Mr. Karaoke and Mr. Sampson is going to cross. Yeah.
So, will you be beginning with
Mr. Karaoke.
karaoke? Okay.
Good afternoon, Mr. Karaoke.
Good afternoon.
I don't know if you can see me, but I'm one of the lawyers representing. You see me, sir?
Well, I see you as part of the people sitting at the table.
Hopefully you can hear me. I just have a few questions. Am I pronouncing your name correctly, Karaoke?
No, but I'm used to it not being pronounced correctly. It's Kiriako.
May I call you Mr. K?
Sounds good. That sounds a lot easier.
Now, on page 5 of your pre-filed testimony, you noted that the application doesn't take into account. You have that in front of you?
Yes,
You noted that the application does not take into account the opening of Encompass's Banbury facility or Pam Health's Waterbury facility scheduled to open in September 30 this year, correct?
correct.
And you're aware that neither Danbury nor Waterbury are located within the applicant's primary service area, correct?
I know they're not proximate in the 21 zip codes, but I've always looked at both LTACs and IRFs as being often a regional resource as opposed to just serving a local area.
You reviewed the application and you saw the primary service area with those 23 zip codes, correct?
That's what you identified, yes.
In that primary service area, Danbury and Waterbury are not local, correct?
Correct.
In fact, there are no licensed IRFs in the primary service area, whether freestanding or hospital setting, correct?
If you're asking whether there are any licensed facilities, no. If there are, it's a question really of what facilities serve rehab patients as opposed to just whether there's an IRF. And again, Gaylord serves a significant number of rehab patients from those 21 zip codes.
I appreciate that, but I'm asking you to focus on licensed IRFs. There are none in the primary service.
Physically in those zip codes, no.
Now, also on page 5 of your pre-filed testimony, and you're referring to Ms. Chapin's analysis, you state that it raises concerns that could have a significant negative impact on Gaylord or Yale New Haven. See that?
Yes,
And likewise, if you could turn to page 7 of your pre-file testimony.
yes, I'm on 7.
You also state that you have a concern that Gaylord and the Yale New Haven would potentially lose material portion of volume in Branford facility. See that?
Yes,
You are aware that Yale New Haven IRF has not entered this proceeding and is not objecting to the application, correct?
yes, I'm aware that they are not.
In fact, none of the Connecticut licensed inpatient rehabilitation providers, freestanding or at hospital base, have objected to the application.
To the best of my knowledge, none of them have taken a position one way or the other. They're
No
not
one,
supporting and they're not opposing.
correct, none of them are opposing. Correct.
Yes, I believe so.
Now, in your pre-file testimony and this afternoon, you were critical of Ms. Chafin's needs methodology.
Yes, because it doesn't include Medicare Advantage's significantly different utilization rate.
And you testified during the Danbury proceedings, correct?
Yes, I did.
No.
No, I didn't. It was the
Objection.
Pam.
My mistake, that's correct. Let me ask you, are you aware that in the Danbury proceedings, Ms. Chafin presented a needs analysis using the same national data, and that needs analysis was accepted by OHS and formed the basis for the approval finding need for the facility?
Well, I believe Ms. Chafin made a comment earlier today that Medicare Advantage utilization data was not readily available. And in fact, it is available. And I'm sure as data becomes available, the state will want to use additional information to make its decisions.
I appreciate that, sir. But my question is, are you aware that Ms. Chafin's analysis in the Danbury proceedings were accepted by OHS?
I'm not personally aware of it, but I'm assuming from the discussion that you've all had today that it was.
Correct, and I'll represent to you that. You mentioned the Medicare utilization data. That is not publicly available, correct?
It is if you're willing to pay for it, yes.
See, and have you paid for that data?
Historically, we did, and we have had more recent runs of the Medicare Advantage data, yes.
To whom did you make that payment?
We use a proprietary firm, Watson Policy Analysis out of Washington.
If OHS was interested in reviewing that data, would you make it available?
I would defer to our attorneys. Are there any issues related to that agreement that we have with?
Your attorney.
We have to verify it, but I have a vague recollection that we did submit it in the PAM application, but I wanted to verify that so we can consider dealing with that as a late file.
Okay.
And in the proprietary data that you paid for, do you know if the Medicare Advantage data is done by geographic location?
It is done. I had the data run on a statewide basis.
So it's not a geographic location.
It's not, the state is not broken down into the planning regions, for instance. It is just on a statewide basis.
And are you also aware that the needs methodology presented in the PAM Waterbury CO1 hearings included nationwide data?
What I assume it was, yes. I don't remember it in detail, but I'm willing to acknowledge that if you're asking the question, you probably know the answer.
And I'll represent to you that it was, and it was accepted by OHS and formed part of the approval by way of a settlement.
I do want to clarify one thing.
Yes.
The methodology was the same. The applications were approved, never specifically endorsed the methodology of the health plan. So, just to be clear on that point.
The methodology was accepted evidence and part of.
Right. But it wasn't part of the final decision. It didn't say we endorse this methodology.
But it made a finding of need and approved the application based upon the evidence. Thank you.
Subtle difference, but
And it's totality.
But if I can make an additional comment,
Mr.
There
Mr.
is-
K, there's no question pending.
okay,
Now, you did an alternate bed needs analysis that's attached as Exhibit D to pre-file testimony, correct?
yes,
And your own analysis shows a need for inpatient rehabilitation beds ranging from 13 to 36, correct?
well, using Connecticut specific data, it's 10 at 100% and 13 at 80%. And if you use national utilization data, it ranges from 29 to 36.
Right, and that's what you included, showing a range from 13 to 36, correct?
Depending on which set of utilization rates you use, yes.
And you heard from Ms. Chapin this afternoon, and she corrected the math in your table and updated the population with 2031 population, reflecting a 5-year planning horizon. And with that analysis, it shows a 40-bed need under your approach using data, correct?
Well, I disagree that there are errors in my calculation, number one, and number two, all the data that was in the CON and including table 3 and table 9, which were the bed need methodologies, used 2030 data. So I'm not clear on why suddenly we're utilizing 2031 data.
And you heard Ms. Chapin's testimony this afternoon.
I did.
Now, finally, Mr. K, Gaylord's average length of stay is 31.7. Its percent of patients discharged to the community is 39.8% using CMS data. Aware of that?
I know I'm not allowed to object, but it's incorrect, and we corrected the record twice now.
Right.
um,
I disagree with the statement, the way you're phrasing it, because we have clarified that several times today.
Well, are you disagreeing that using CMS data, Gaylord's average length of stay is 31.7 and percent of discharge to the community is 39.8?
I think the previous testimony has clarified that question. I'm not an expert in that area. Mr. Gravelding and Ms. LaBarbera are the experts, but I think we have addressed that question several times.
I was asking you to just focus on CMS data. Have you had an opportunity to do that?
I have not looked at, what website are you looking at?
It's in the PowerPoint presentations, and the references are in the footnotes to CMS data.
In my references?
It's the Medicare Compare.
I have
Yeah.
not looked at, I have not looked at the Medicare Compare data recently, no.
And the record's the final arbiter, and it is in the record. Thank you very much, Mr. K.
Attorney Letty, did you need to clarify anything? I'm not going to allow like a full redirect.
No, it's not a full redirect. It really is a question that's more appropriate for Mr. Gravelding to begin with, and I whatever testimony that came from Kiriakou, it's limited to putting this discussion about discharge rate is something that Mr. Rebelding can address and has addressed. And so we would prefer that the question be asked of him.
So either Attorney Rocha or Attorney Sampson, you can ask that question of him perhaps, and maybe we'll get a better answer.
Thank you. For the record, Patrick Sampson on behalf of the applicant. Mr. Gevelding, good afternoon. Gaylord Hospital is a Medicare certified long-term acute care hospital, correct? True to its certification, it provides long-term services to its patients, correct? And would you agree that Gaylord specializes in the care of medically complex and complex rehabilitation patients? Okay. And according to CMS data, Gaylord's average length of stay is 31.7 days, correct?
A narrow look of the data of CMS fee-for-service Medicare population. I think it's fee-for-service. I need to go into that. Again, we're getting into first little data holes, but if that's what's on the MedTech Compare website, I would say that's the data that's submitted. Usually, it's got a lag of about 2 or 3 years. So about 2 years, about 2 years ago then.
And Gaylord is not a Medicare certified IRF, correct? And you agree that there are different CMS requirements for LTACs and IRFs? And by way of example, an LTAC is required to have an average length of stay of 25 days or more, correct? And Gaylord's.
Oh, actually, yeah, good point. 25-day length of stay for fee-for-service. That's a specific regulation, just like, with the IRFs, it's 60%, 60%, 13 diagnosis. We all have our own little nuanced regulations, correct? And that's why with the Medicare Advantage, when we look at this, it's a challenge for us now as the Medicare Advantage population goes up. Our population for the 25-day length of stay regulation comes down. It's a challenge.
And an IRF does not have a length of stay requirement, correct?
Not to my knowledge, I'm not an expert in the IRF regulations.
And you did hear earlier today that Encompass Health's average length of stay is approximately 12 days. And an IRF, is it your understanding that an IRF must provide a minimum of 3 hours of therapy a day, 5 days a week, or 15 hours of therapy over 7 days?
It's 150 minutes. Is that the regulation?
Is it 3 hours a day, 5 days a week? Is that your understanding?
That's what was stated earlier. Again, I'm working in IRF, 22 years ago, for a few years when I started my career. It's been a long time since I've been there, and certainly not an expert in the regulation.
Mr. Gevelding, if you could just speak up a little bit. All right.
That usually doesn't occur. Okay.
And Mr. Gevelding, there is no minimum therapy requirements for LTACs, is that correct?
That's correct, which is the beauty of, as somebody that's working both IRF and LTAC, I'm able to treat somebody the way that they need at that time. So those patients, I think we brought up earlier, the vented patients, we're able to build that tolerance as they go and build up and sometimes go beyond 3 hours. So we're able, as a care provider, to determine that need.
Okay, and are there certain patients at the LTAC that may not require any rehabilitation when they first arrive?
No. Not the way that we no.
And NERF, your understanding that a NERF must have an MD or a DO rehabilitation director?
I can't testify to the regulations of it, or I don't know. But good point. We actually do have a medical director for our, that is the physiatrist for our rehabilitation.
And you agree that the goal of an LTAC and an IRF is to discharge the patient back to the community in the best condition as soon as possible? And you heard earlier that IRFs have a better discharge rate back to the community than LTACs, correct?
Correct. Again, from the admission criteria standpoint, when we look at those severity, we look at that severity piece, we would expect, and I believe, and again, not to ask a question, but I believe the regulations are that there's a certain percentage discharge to the community from an IRF, otherwise there's penalties, but I'm not sure. Again, I don't know the regulations very well. So the admission criteria would obviously lean for that.
And you heard earlier that Encompass returns approximately 70% of its patients back to the, correct?
Somewhere around 50%.
And are you aware that the national statistics show inpatient rehab hospitals discharge patients back to the community by a rate of 67% approximately, compared to 50% for nursing homes and 17% for LTACs?
Again, we're looking at national versus state, versus whatever data. Yes, those are the national statistics looking at different classes of groups. But again, if we're talking about us in Connecticut and what we do, it's different, as we've tried to share with the hearing officers.
And Medicare payments distinguish between LTACs and IRFs, correct?
Two separate payment models.
And what are those two payment models?
We are DRG based, and I believe you are CMG based. Similar in that they're diagnostic groups.
Two different models, like you said. And you heard earlier that an LTAC hospital is paid $50,824 approximately per case, while an IRF is paid $27,119 per case approximately. Is that correct?
That's what was on the slide. Yes, I saw that on the slide. And the per day rate, I think, on IRF a little lower in LTAC.
Now, you discussed in your pre-filed testimony the types of patients treated by Gaylord compared to the types of patients treated at an IRF, correct? And first, I believe you stated in your pre-filed testimony that there are patients who are suitable for an IRF who should not be discharged to an LTAC, and patients who are suitable for an LTAC who should not be discharged to an IRF, correct?
See it exactly that way. You would not discharge to an IRF. LTAC would not discharge to an IRF. I just want to make sure that was that direct quote. But I think what you're going for is that there's teaching for each organization, and there's some overlap.
What I'm asking is, a patient is discharged from an acute care hospital. There are certain patients who may be appropriate for an IRF and certain patients who may be appropriate for an LTAC, correct?
Correct. Like I said in my speaking here, like a hip fracture to the IRF and a patient on a ventilator to an LTAC, correct?
And in your pre-filed testimony, and when you were just speaking earlier, you mentioned that there were 13 CMS diagnosis codes that had to make up at least 60% of admissions to IRFs, correct?
I think, again, not an expert in IRF regulations, but yes, that's the way I understand it.
And would you agree that patients diagnosed with one of those 13 CMS codes may not be able to withstand the required 3 hours of therapy 5 days a week at an IRF?
Can you restate that?
Sure. So
There's a lot to that one.
no, that's fine. So a patient who is diagnosed within one of those 13 codes, that particular patient may not be appropriate, may not be able to handle 3 hours of therapy 5 days a week at an IRF. Fair to say?
So are you asking that you would admit somebody that couldn't handle 3 hours of therapy?
So I'm asking if a patient that has one of those 13 codes, just because they have that code doesn't mean they could tolerate the hours of therapy 5 days a week.
Based on admission criteria, we all look at where they should go appropriately in the continuum of care, whether you're saying whether they go to SNF, LTAC, or IRF. I agree with that.
Would you agree that a patient's diagnosis code is not necessarily indicative of their overall medical condition?
I agree with Dr. Charbonneau that each case needs to be looked at individually. And the whole point of what we're talking about is that each one needs to be looked at. We can't just look at these diagnosis groups. These 13 go to IRF, and they don't go to an LTAC. We need to look at each from the severity of what's going on for that person. Can they be moved from the acute care? Can they tolerate therapy? What's the and where? What's their ultimate functional plan at the end?
And would you agree that an LTAC is able to serve a more acute patient population than an IRF?
Yes.
And you mentioned in your pre-filed testimony severity of illness level 2 or 3, correct? And the whole scale to be complete here, 1 through 4. Do you agree that a patient on the severity scale level 2 or 3 may be discharged to the IRF rather than Gaylord?
That's the whole area. I think, again, looking at the individual cases, yes, they're probably could stretch a little bit on the most severe, but there could be some overlap in that group. That's the whole point of that.
And so if a patient is, and would you agree if a patient is in one of those two severities, level 2 or 3, they would have to be able to tolerate the 3 hours of therapy, 5 days a week, meet the IRF admission?
Your team knows the admission criteria much better than I, but that's from what I understand. Yes, meeting the 3 hours of therapy. There's a variety of expectations to how fast they can do it off the bat and whatnot. I don't know those off the top of my head. I remember reading my area of expertise.
Yes. And on page 3 of your pre-filed testimony, you mentioned that patients that the applicant hopes to serve are currently being served by an LTAC, an IRF, or inpatient rehabilitation unit of a hospital, a skilled nursing facility, or a home care provider. Is that correct?
Can you tell us which page? I'm sorry.
It's page 3.
I'm sorry, can you
Yeah.
start the sentence one more time?
Yes. It's patients that the applicant hopes to serve currently being served by an LTAC, an IRF, or inpatient rehabilitation unit of a hospital, skilled nursing facility, or a home care provider, depending on their level of acuity, payer requirements, and choice. And other than Gaylord Hospital and Hospital for Special Care, other LTACs, IRFs, IRUs, skilled nursing facilities, or home care providers sought intervener status to object to this proposal. Is that correct?
We've said it a few times and either. So to answer your question directly, no.
And then in your pre-filed testimony, you mentioned that Gaylord serves as a clinical site for the Yukon School of Medicine, Physical Medicine, and Rehab Residency Program, correct?
Correct.
You stated that if patients were diverted from Gaylord, residency could fall below required case volume thresholds, jeopardizing the residency program, correct? You also mentioned in your testimony research that's conducted at Gaylord, correct? And research at Gaylord depends on meaningful patient participation, correct? And are you familiar with Connecticut's Certificate of Need statutory scheme?
That's it. Be you more specific in that?
The requirements that an applicant needs to meet in order to receive approval of a certificate of need. In your pre-filed testimony, you also mentioned some concerns regarding staffing if the application is approved, correct?
Correct.
You heard earlier today that Encompass sets staffing pay scales based on existing pay scales within state or, in this instance, Connecticut, correct?
I heard that earlier.
Nothing further.
Thank you. I guess we will move on to the chief of hospital for special care. Howard, do you want to introduce your witness?
Yes, this is the CU and Chief Financial Officer.
Ms. Redmond, can you please raise your right hand? You solemnly swear or solemnly and sincerely affirm, as the case may be, that the evidence that you shall give or have already given in this case shall be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury. Dr.
I do.
You can proceed.
Thank you. Good afternoon, and members of the Healthcare Strategy Panel. My name is Lori Brodman. I'm the Senior Vice President of Finance for the Hospital for Special Care. We are a 236-bed chronic disease hospital licensed in the state of Connecticut and a Medicare certified long-term acute care hospital located in New Britain and Hartford. specialize in caring for adults and pediatrics, some of which have the most complex and catastrophic medical conditions in the state. More than 80% of our patient days are Medicaid, and nearly all of our pediatric cases are funded through the state. In addition to our inpatient beds, we also offer outpatient services that range from a sophisticated autism center, as well as movement disorders, and also including neuromuscular, and also a therapeutic riding program. All of these programs come with external accreditation and also national recognition. These programs underscore the hospital's key role as a safety net provider within the state of Connecticut who cares for the most fragile and eligible Medicaid patients. I'm here today to respectfully urge OHS to deny Encompass's Branford application for 50 beds. The inpatient location, I want to focus on 3 main points. One being, we have not demonstrated a public need. We have unnecessarily duplicating existing rehabilitation services, which you have already heard about, and also increased costs. Third, it would worsen the workforce shortage within the state of Connecticut and risk the financial stability of the hospital for special care, along with other post-acute care providers. Let me start with public need. Encompass's need argument rests largely on 2 observations. First, Connecticut's aging population and the fee-for-service Medicare IRF utilization rate, which we've heard an awful lot about today. Just because it's lower than in many other states, while SNF utilization is higher in the state of Connecticut, lower IRF utilization compared to other states does not itself prove that Connecticut patients are experiencing any delay or care for inferior clinical outcomes or restricted from access. The application does not include Connecticut-specific data, and that's something we've also heard about, and it does not show that patients are harmed by any of the care that they're currently receiving, whether it's in a SNF, chronic disease hospital currently, or in a home health. Importantly, OHS has long regarded hospital-based IRFs as medical surgical beds that have been reallocated as hospital licensed, and their capacity can change based on the need of the population. That means hospitals already have the flexibility to increase IRF bed allocation when they see growth need. In fact, we've talked about Yale New Haven's current existing IRF on the shoreline is operating at 77% capacity, and Lawrence Memorial is only at 59% capacity, based on recent OHS data. Encompass projects 40% of their referrals to come from Yale New Haven Health into the Branford facility. Encompass's volume assumptions are further undercut by the new federal payment system, which we've also talked about, the team approach. And we also know that Yale and Midstate are both required participants. They're not voluntarily participating, they were required. And it begins in 26, 5-year period. We've already heard that first year there was no financial impact to any of the organizations, which we've heard that there's no change in any admission data currently in the current IRF, but there's also no financial impact. Team's bundled payment system with the surgical procedures and the 30-day episode of care. We've already seen the previous Medicare bundled payment systems where financial responsibility, when it rests at the acute care hospital, that episode, they are less likely to discharge to an IRF or any other post-acute care provider. They're going to keep those admissions in-house within their own system. Traditional Medicare IRF payments for past bundled payment, we've seen, and Medicare has reported on, that 1/3 of the revenue has declined under those bundled payment systems. That's important to note. It is a reasonable expectation that over this 5-year period of the team that we should expect similar results. that makes the projections in this proposal even less credible. The second that I want to talk about is duplication in existing service added costs. Connecticut, as we've also heard today, has already approved and recently added new IRF beds, and the capacity that they're drawing from might not be in the zip code area, but it's drawing from the entire state of Connecticut. That is really important to understand. The certificate of need for Waterbury, which has not even opened yet, they have the opportunity to expand the beds that they can increase to up to 43. And Danbury, as we know, just opened in the fall. Both Waterbury and Danbury, our target referrals are coming from the same referral sources. And there is overlap. There's a lot of overlap with the acute care hospitals and their discharge. And Connecticut is a small state. We simply do not know yet the full impact of what these new IRFs are going to have as an impact on our current system. That's important. Approving another freestanding IRF at this point, we feel is premature and risks creating excess capacity. There is also a disconnect between the applicant's narrative and what Connecticut hospitals have reported as post-acute care bottlenecks. We have not heard that there are bottlenecks of getting patients out for rehabilitative services. But what we have heard is through the General Assembly, the Connecticut Hospital Association has reported that there is trouble placing patients on ventilators, ventilator patients needing dialysis, behavioral patients, also eligible patients that need DDS services. These are not IRF level patients, and these are people served by long-term hospitals and other highly specialized settings. CHA did not identify a shortage of IRF beds in any of their policies. At the national level, MedPAC in March of 2025, they reported to Congress and concluded that IRF access is adequate. It cited an overall IRF occupancy rate of 69% based on the evidence, and it also noted a very high traditional Medicare profit margin, around 18% for hospital-based facilities and 40% profit margin for freestanding IRFs. These margins are strong and they're signals that providers have a financial incentive to treat Medicare patients in IRFs, and actually they recommend reducing IRF rates. That did not happen, but their recommendation went forward. This is not a portrait of an undersupplied sector and required additional beds to protect access to care. The cost implications are also significant. In December 2025, MedPAC analysis found that traditional Medicare IRF costs were 21% more than skilled nursing facility stays, even though the IRF stay was less than half of a SNF patient. At the same time, Connecticut has one of the highest, we've talked about, Medicare Advantage penetration rates in the country, but 63% of the beneficiaries in 24, compared to 54% nationally. Medicare Advantage plans are generally more likely to direct patients, lower cost SNFs and home health agencies instead of an IRF. Encompasses, we've also talked about this. Their own data has shown a recent downturn in the Medicare Advantage patient population, and adding a new IRF capacity on the assumption of a robust traditional Medicare volume in a state dominated by Medicare Advantage is a risky proposition that does not align with payer behavior. Third, and most importantly, from the Hospital for Special Care, our perspective is that this project will worsen the workforce shortages, threaten the financial stability of other providers. As OHS knows, labor is the largest expense in inpatient care, and all post-acute care providers in Connecticut are competing for the same labor pool. Nurses, CNAs, physical therapists, doctors, respiratory therapists. A 24 Mercer report projects that Connecticut will face shortages of nearly 6,000 healthcare workers by 2028, including 900 physicians, APRNs, 1,000 registered nurses, CNAs. The Connecticut Department of Labor's own projections show that there's a substantial shortage in openings across rehabilitative facilities, and they expect that to continue through 2032. HSC is living that reality now. We currently have 53 vacant clinical positions, and 33 of them are registered nurses, 14 CNAs, 5 respiratory therapists. Despite relying on the cost of travelers to fill the gaps in all of these, contracted labor alone has added $2.5 million to our operating budget, which just started on April 1st. And we expect that to increase as the openings continue. Even with these measures, there are times we have had to halt admissions and slow down and limit access in our census to the hospital because we cannot safely care for the patients. So adding additional patients into the system to further care, we're not able to do that. Against that backdrop, the applicant projects needing 89 clinical FTEs, but I heard a range of 143 to 150. So the data that we had, I guess it's even greater of a need. Those staff will be drawn from the same constrained labor pool that HFSC and other post-acute care providers, including Gaylord, currently draws from. For a hospital like ours, where more than 80% of our patients depend upon Medicaid and are ventilated dependent patients with nowhere else to go. Further, we'll put pressures on wages and an agency usage, which will be devastating hospital. Financially, HSC already operates on negative margins. The testimony reflects that for our fiscal year that just ended in 2026 in March, we'll project a $500,000 operating loss. And next year, our budget is projecting a $6 million operating loss. These losses are not sustainable for an independent, not-for-profit healthcare whose mission is to care for the state's most fragile patients. Approving an additional for-profit IRF, which will aggressively compete with scarce clinicians in our state, risks undermining our ability to continue as a going concern. To be clear, this is not an argument against a rehabilitation hospital. IRFs play an important role in the healthcare post-continuum of care. The question before OHS is whether Connecticut needs an additional 50 beds at this point of a freestanding IRF. On top of the new capacity in Danbury and Waterbury that are evolved and with the evolving federal payment system. Available evidence does not show an unmet need of IRF patients in the state of Connecticut. We're not talking nationally, we're talking in this state of Connecticut. It does show unused capacity in existing units, significant new beds. IRF have already been approved and opened, national data demonstrating adequate access and high profit margins. A workforce and financial environment in which another for-profit would exacerbate existing strain on safety net providers within the state of Connecticut. For these reasons, we respectfully ask OHS to deny the application. Should a genuine additional IRF be needed in the future, we would welcome the opportunity to work with existing Connecticut providers that already provide this level of care, including HSC. We'll work with the state to meet that need in ways that preserve the quality and costs and safeguards to stability in a current delivery system. Thank you for your time and opportunity to present this testimony, and I'm open for questions.
Right then, Attorney Cowherd, did you have any direct questions here?
This time I may want to clear to the anything that's said on cross.
Attorney Rudman, are you prepared to move forward?
Good afternoon, Ms. Rudman. I'm Pat Rocha, representing the applicant. You've been very patient. It's been a long afternoon, and I just have a few questions. So first, Hospital for Special Care is Medicare certified long-term. And you testified that, and I'm going to refer to it as special care. You testified that special care provides long-term acute care services and many of your patients who have complex and catastrophic. And you provide services to special care, provides services to adults and children. Special care also operates outpatient autism centers you mentioned and a therapeutic center, muscular center, correct? And that's a terrific service, state of Connecticut. But you understand that Encompass provides one service, and that's intensive rehabilitation therapy. Now, you were present when Dr. Charbonneau testified, and you saw her slide 12, which uses CMS care data as of April 14, 2026, and it showed a length of stay for special care of 99.9. Call that?
Yes,
And that's consistent with the patients that you're serving have complex conditions.
complex, correct.
Now, special care is not a Medicare certified inpatient rehabilitation hospital.
You're not.
And there are different CMS requirements for LTAC and IRF certification and admissions, correct?
That's correct, based on what I know.
And you know that LTAC is required to have an average length of stay of 25 days or more. And in fact, special cares is 3 times that, and that reflects the patient population that you're serving, that you described.
Attorney Broca, I'm just going to object. I think this is repetitive in the sense that unlike the hospital for special care, and I'm being respectful, we did not put up a clinician. These points that you're alluding to have already been brought out in the record. If there's something more specific, I invite you to do that. And I'm just saying this in the interest of time also. So
I'm going to let her, to the extent that you're answer the questions,
I can't.
answer them, and if you then you can't answer.
And you're aware that an IRF has no length of stay.
Not familiar with the IRF regulations, but if you say so.
And in fact, you were present when Dr. Charbonneau testified, again, referencing slide 12 with CMS compare data that the average, national average for IRF length of stay is 12.5 and Encompass is 12.2. And you're aware that an IRF must provide, we've heard it all afternoon, therapy of 3 hours a day, 5 days a week, or 15 hours over 7 days. And you do know that there are no minimum therapy requirements for an LTAC.
I am aware of that.
And an IRF must have an MD or a DO as a rehabilitation director, and there's no such requirement for LTAC.
There is not a requirement, but our hospital has it.
Now, I want to spend a minute on discharge to community rates. And you would agree with me that a goal, whether it's LTAC or an IRF, is to get the patient back to the community, whether that's home or SNF, as soon as possible. And you also heard from Dr. Charbonneau that Encompass's national average is 70.3%, correct? Using the CMS data.
Well, shown.
And using that same CMS data, do an apples to apples comparison, Hospital for Special Care has 41.1%. And you also heard that Medicare payments distinguish post-acute care between IRFs and LTACs. And you heard the testimony showing that per case, LTACs are reimbursed, I think it was $50,824 compared to IRFs at $27,119. And again, that's a reflection of the type of patient that you're servicing, medically complex.
The average cost per day is also lower.
Sure.
Based on the.
And as an LTAC, you're reimbursed per case, correct?
That's correct.
And that per case reimbursement shows the higher reimbursement to the LTAC compared to the IRF, reflecting the type of patients that you're servicing.
I would like to clarify, though, that long-term acute care hospitals are also able to admit IPPS cases, which are short-term rehabilitative cases. So that's an important distinguishment. It's in addition to the long-term acute care hospital. That regulation changed a few years ago.
And as an LTAC, you can,
Sorry, you said IPPS.
IPPS, which is a standard acute care hospital reimbursement rate. So we actually have the ability to get reimbursed under two payment systems. One for the long-term acute care and one for the IPPS, which is an acute care hospital, which has a very short length of stay.
We just like to, we just like to get our acronyms. Medicare Inpatient Prospective Payment System.
IPPS is actually what an acute care hospital gets reimbursed for their inpatient population, as opposed to a long-term acute care hospital.
Sometimes called site neutral.
Yes, site neutral payment. So we do have cases that come in and might stay for 5 days, 10 days, and we get reimbursed a different rate, which is much less than that $50,000. Could be 20,000, could be 15,000, depending. Again, it's based on DRG, but has a much shorter length of stay, and it's based on the acute care hospital model.
but special care cannot bill as an IRF.
That's correct. We're not in IRF, but we do have, under current Medicare regulations, if we saw a need that would precipitate us wanting to open an IRF, Medicare would allow us to open an IRF within our long-term acute care hospital. And that regulation was changed, I don't know, within the last maybe less than 5 years, give or take. And we don't see that need and can care for those patients under the two current existing payment models.
So are you testifying that you are providing IRF certified services as an LTAC provider?
Not IRF. There is overlap, as you've heard today, and it's similar here at the Hospital for Special Care. Yes, testifying too.
Now, you testified about patients' complex medical needs on ventilators needing dialysis. And obviously, those patients cannot withstand the required 3 hours a day of therapy that IRFs required to give, correct?
That I cannot respond to. There may be an occasional case, and again, it's dependent on the patient, whether they can withstand being on a ventilator. They might not be on a ventilator 24/7. They might only be on a ventilator at night, and therefore they might be able to do therapies.
And you would agree that determination of the needs of the patient are based upon the patient's medical condition, not the diagnosis from the referring hospital.
Jack, again, this is well outside the scope of a written testimony hearing, officer. It's not a clinician. This has been, there's none of this in her written testimony. It should be the bounds of the public, especially if we are trying to this hearing.
Attorney Roach has plenty of time. We're not trying to move things.
Okay.
She's
I'm just objecting to the scope. The cross should be within the scope of the witness's testimony.
understood, but you entered some exhibits that we weren't expecting either, and we have to have some flexibility, and to the extent that she's able to answer the questions.
Just wanted to raise the objection.
Ms. Rudman, in your pre-file testimony and comments this afternoon, you talk about a 500,000 operating loss for the fiscal year ending March 31, 2026, correct? And you also testified that you anticipate a $6 million operating loss for the current fiscal.
Yes.
Fortunately, you're in the same boat as many, many healthcare providers, correct? Now, obviously, the applicant had no role to play with those operating losses, correct? Your fiscal year ending 3/1/26 and is current.
That would be correct.
And like every healthcare provider, special care has an obligation to manage its operations reasonably, and you'll take appropriate steps to improve financial performance so that you can provide quality services to your patient base, correct?
That's correct.
Have a moment. I have nothing further.
Just one clarification. Your knowledge, as you stated, within staying within the 25-day length of stay, we can still provide services to patients that don't require that long stay.
Oh, absolutely. We have patients under both payment systems, whether it be the short-term IPPS cases or those that come on under long-term acute care and will stay very short periods of time. So the 25 is an average over a 12-month period. So at some points, we could be at 20, we could be at 19. Medicare gives you a period of time in which after your fiscal year, you could self-correct to make sure you get up to that 25 so that you are still considered long-term acute care hospital. If you don't, then you'll have to work with Medicare and they would designate you as an IRF.
Questions. So, it's been testified to hospital for special care and it's a payer mix 80% Medicaid. But beyond that, you also have Medicare reimbursement and commercial reimbursement. Correct?
Correct.
How important is that remaining 20% of your reimbursement to the hospital special care and your financial liability?
For every 1% of a reduction in our referral base, that's going to cost the hospital over $200,000. So that 10% is very important to the hospital.
Just for clarity.
For clarity.
Yeah, we're talking about Medicare and commercial.
Correct.
So that went a little bit beyond what Attorney Rocha was asking in terms of cross-examination. So do you have any follow-up questions that you wanted to do? Well, it's 4:05 right now. We're going to take a 20-minute break. OHS is going to convene and figure out which of our questions we can knock off the list. So let's plan to come back at 4:25. If we start sooner than that, we will, but our end of the spectrum is 4:25. So thank you, and Faye, oh, I'm sorry.
Matt, it's my understanding there may be one person